Good afternoon, everyone, and welcome to our webinar. We'll just wait another 30 seconds or so for people to join, and then we'll get started. I am Mandy Sankuler, your Director of Partnerships and Communications, and it's my pleasure to be here today to introduce our newest webinar on AL amyloidosis. This is a subject that we have never looked at before from an education standpoint, so we're really excited to be able to bring you this information today and to tell you more. Before we start with an introduction, just wanted to let you know that you are in a listen-only mode. You will not be able to answer any questions related to your specific condition, but if you do have questions, we encourage you to go back to your healthcare team and ask them to those doctors and nurses. Please type your questions into the Q&A box or the chat box so that we can answer them at the end of the presentation. And please note that the webinar is being recorded and will be available on our website and YouTube channel tomorrow. We also wanted to take a moment to thank our partner on this webinar, Alexion. With their support, we are able to bring you this education. And now it's my absolute pleasure to be able to introduce you to our presenter on today's webinar. Professor Wechalekar is an internationally renowned consultant hematologist who specializes in plasma cell disorders with a focus on MGUS, multiple myeloma, monoclonal protein-related disorders, and all types of amyloidosis. He is part of the largest UK melanoma service and leads hematology at the National Amyloidosis Center, as well as the AL amyloidosis treatment program. Professor Wechalekar is also the director of the laboratory at the National Amyloidosis Center. He is active in clinical research, developing a trials network in the UK for AL amyloidosis, and acting as principal investigator, chief investigator on a number of amyloid clinical trials. He has published widely both nationally and internationally in these areas. And it's a real pleasure to have you here today, Doctor. Thank you. I'm going to go ahead and stop share, and I'll let you take it from here. Thank you.
Thank you, Mandy, for that very kind introduction, and also for asking me to talk today about AL amyloidosis or systemic amyloidosis. Can you see my screen?
We can. Thank you.
Thank you. So my role today is to talk to you about light chain amyloidosis, or AL for short. We will go through what is amyloidosis, how amyloidosis can affect your body, and then we'll briefly touch on how it's treated and managed. So what is amyloidosis? It's a disorder of proteins. Our body is full of proteins. They are liquid proteins in the blood. There are solid proteins in the skin and the muscles. And we generally don't like these proteins to change their form. So when different proteins become abnormal, they start sticking to each other. And they stick to each other and they form these fibrils. And when you look at these under different microscopes, and these are long rope-like fibrils made of proteins, and that's really what amyloid is. It's a term for solid protein fibrils. And what happens is that when these proteins go from their native structure to form these fibrils, they get a lot of different properties, one of which we exploit for diagnosing the disorder. This is called as Congo red stain. Some of which we exploit for imaging the amyloid protein. This is a scan we use for diagnosing amyloidosis. But really, the main problem is that these proteins become very, very stable. They are proteins which the body can't dissolve, the body can't get rid of, and therefore they keep on accumulating in the tissues, leading eventually to tissue destruction and damage to the functioning of different organs. Now, amyloidosis is not one disease, but it's really many different diseases where we end up in the final form, which is amyloid fibrils. It can be related to proteins which we all have, like transthyretin. This is a protein we all have. It carries a thyroid hormone. It misfolds, binds to some normal proteins, forms these little chains called oligomers. These oligomers will then assemble to form these long amyloid fibrils. Sometimes we have got immune cells in our body called plasma cells. Their normal function is to make antibodies, and these antibodies can then form abnormal amyloid fibrils. Other kinds of amyloidosis happen for patients who have underlying inflammatory conditions, such as rheumatoid arthritis or long-standing infections, where the infection markers tend to be very high. And these very high infection markers release a protein called SAA, which then misfolds and forms amyloid. There are about 36 different types of amyloidosis which have been described, and more recently, with newer technologies to be able to diagnose these fibril types, we are getting even more types of amyloidosis being typed. Now, this was looking at patients who were seen in our center until 2019. And this is nearly about 7,000 or 8,000 patients that we have seen in our center over the years. And as you can see, over the years, amyloidosis has been increasingly recognized. And we have been seeing more and more cases as time has gone by, as patients are being diagnosed, but also patients are living longer. When we look at the spread of patients with different types of amyloidosis that we see in our center, light chain amyloidosis, or AL amyloidosis, is the commonest type of amyloidosis that we see. And then that accounts for about 50 to 55% of all the patients. Sometimes the AL amyloidosis might occur at one single site called as localized AL amyloidosis. We used to see quite a lot of inflammation-related amyloid, but that has now become relatively uncommon. And then we've got this type of amyloidosis called wild-type transthyretin amyloidosis, which happens when the amyloid protein deposits in the heart in older adults. And this is the gray bar you can see. And until 2010, maybe we saw a few patients with this. But this is a rapidly rising diagnosis. And now, if we ran the same pie chart this year, we'll probably find that AL amyloidosis and wild-type ATTR amyloidosis are probably as common as each other. We do see about 15% of patients where amyloidosis can run in families called familial amyloidosis. Again, the commonest of this type is transthyretin. But there are other proteins such as fibrinogen and some of the other proteins which can cause familial amyloidosis. So about 10 to 15% of patients that we see in our center, the amyloidosis can be familial. The amyloidosis that we are going to talk about today, which is AL or light chain amyloidosis, is typically not familial. So what is AL amyloidosis? In AL amyloidosis, we have got abnormal immune cells called plasma cells. We all have these immune cells in our body. Their normal function is to make antibody proteins. This is what an antibody looks like. If you get an infection, influenza, COVID, bacterial infection, your body will produce specific antibodies to tackle those infections. Sometimes these plasma cells, which are producing these antibodies, go wrong and start producing an abnormal type of antibody. Now, having an abnormal antibody in the serum is incredibly common. It is a condition called as monoclonal gammopathy of uncertain significance. Maybe 5%, 8% of the population will have a small trace of an abnormal protein, which is usually benign and it really causes no problems. But sometimes these antibodies have very peculiar conformation. They are very unstable. The antibody is a complex structure made of these very big chains called as heavy chains. And stuck onto that are these little protein chains called as light chains. These light chains are attached, as you can see here, to the heavy chain, which is a full immunoglobulin. But in AL amyloidosis, these light chains are produced in excess and they are not attached to this big heavy protein. These light chains will misfold. Once they misfold, they open up and they start sticking to each other. And then they will start forming these long fibrillar protein strands called amyloid fibrils, which then go deposit into different tissues and different organs. AL amyloidosis is a relatively uncommon disorder, probably happens in 8 to 10 patients per million population. Since the antibody conformation, the antibody structure is quite different in every patient, light chain amyloidosis can be quite different in different patients, and what happens in one patient may not necessarily be replicated in another patient. These proteins can stick to more than one organs, and the symptoms that a patient will present depend on which organs are affected and how damaged those organs are. So if the organ is mildly affected, the symptoms may almost be not noticeable, to very significant symptoms because an organ isn't functioning as well as it should. ATTR amyloidosis is a very different type of amyloidosis called transthyretin amyloidosis. This is an amyloidosis which happens because this protein called TTR or transthyretin deposits in the heart as one gets older. It may be very common and may affect a large proportion of population. It typically causes the heart to become very stiff. and causes a condition called as heart failure with preserved ejection fraction. And even within the UK, maybe 10 or 14% of these patients may have amyloidosis, and there may be as many as 50 or 60,000 patients with this type of amyloidosis, whereas AL amyloidosis is a relatively rarer disorder. This type of amyloid is typically in older adults, still not identified as much as we think it should be. And the reason why amyloidosis is such a challenge is that it can involve any organ or any organ system in any combination. This was a study done by the Amyloidosis Research Consortium in the US, and it tells you how many times a patient had visited a physician before the diagnosis was made, and which type of physician made a diagnosis can be right from a primary care physician, right on to the hematologist, cardiologist, nephrologist, or the gastroenterologist. And the reason amyloidosis is so difficult to diagnose is that because it involves any organ, the symptoms are very common. You may be a bit tired, there may be a little bit of edema on their feet, occasionally a bit of tingling which comes and goes. And once these symptoms have happened in somebody with hypertension, diabetes, or some other problems, physicians don't think of amyloidosis as a cause of these symptoms and relate it to some other common disorder. And there has been as yet no one single diagnostic test for amyloidosis. It's always a combination of tests which leads to the diagnosis. And therefore, thinking of amyloidosis is very, very important. And that's kind of what we're trying to educate our other physician colleagues, that amyloidosis is an uncommon disorder, but it's not that rare. The complications of amyloidosis depend on where the amyloid deposits are formed. In AL amyloidosis, two organs are commonly affected, the heart and the kidneys. About 70 to 80% of the patients will have cardiac involvement, and approximately the same number of patients will get kidney involvement with light chain or AL amyloidosis. The other organs which can be affected in amyloidosis can be the soft tissue. The amyloid protein might deposit into the tissues in the tongue, what's called as an enlarged tongue or macroglossia. It can deposit in the nerves, causing tingling, numbness, painful peripheral neuropathy. It can deposit in the gastrointestinal tract, leading to symptoms of early satiety, diarrhea, constipation, feeling of bloating, significant weight loss. Of course, I already told you it affects the kidneys. It can start depositing in the liver. Liver is an organ that has been designed to take a lot of damage, so the amyloid can accumulate in the liver for quite a long time without causing any symptoms. The liver can become enlarged, and then the liver function tests start to become abnormal, leading to other symptoms. And then it can affect what's called as the autonomic nervous system. These are nerves which supply your blood vessels, keep up your blood pressure, but also regulate the functioning of the GI tract, the sweat glands, and amyloidosis can affect all of that. So it becomes quite a tricky diagnosis because it can start in any organ, but it can also affect any of these organs in any combination, 1, 2, 3, or 4 different organs. Not sure why this looks grayed out, but the symptoms can be breathlessness, depending on heart involvement. It can be swelling on the feet, impaired kidney function, or renal failure. It can be diarrhea, nausea. If it affects the autonomic nervous system, the patients might feel dizzy when you stand up because the blood pressure suddenly drops. The amyloid can affect the skin, leading to easy bruising. It can cause skin rashes. It can affect the growth of the nails, and the nails can become quite long and brittle. When amyloid builds up in the tongue may feel very swollen. There may be change in taste. It can lead to quite a lot of dryness in the mouth, difficulty in chewing or swallowing. GI tract involvement can lead to nausea, feeling of early satiety, diarrhea, significant weight loss, and then affecting the peripheral nerves can lead to tingling or numbness, so-called peripheral polyneuropathy. Cardiac amyloidosis, one of the commonest organs affected by the amyloid deposits, causes the heart to become very stiff. It's a bit like thinking about pouring wax into the heart. The heart is unable to function efficiently. It becomes enlarged. It's very stiff. It can't quite fill with blood, and therefore it impairs the ability of the heart to pump efficiently. That leads to edema, which is the commonest symptom, swelling in the legs, maybe the abdomen, even the arms. Leads to shortness of breath, particularly on walking or climbing stairs. Sometimes it can lead to irregular heart rhythm, so-called arrhythmias. Because the heart is very stiff, it's unable to pump a lot of blood at one time, and therefore the blood pressure becomes low. A lot of times we find patients who have a long history of high blood pressure suddenly start to notice that their blood pressure is no longer high. They are delighted that they're no longer hypertensive. but that's because their hearts are starting to get damaged by amyloidosis and the hypertension is starting to resolve. Fatigue is a very common symptom of amyloidosis, can be caused by any different organ involvement, and is often a very, very substantial symptom, often occurring before any of these other symptoms start to occur. Renal involvement, the amyloid proteins deposit in the filtering bit of the kidney, the so-called glomerulus. And these filtering bits of the kidney get clogged by the amyloid protein. They become very leaky. Normally, kidney is meant to block the protein, just let fluid out. But because of the damage, then the protein leaks out of the kidney. The kidneys are not able to maintain their normal salt and water balance. And again, the symptoms are very similar to what I showed you before. A bit of edema because the kidneys are leaking protein, fluid retention. Occasionally, there may be blood in the urine, but that's not a very common symptom. The urine can become very frothy. We need kidneys for helping us to make red blood cells, so patients may be anemic. You may lose your appetite, feel nauseous if the kidney function starts to deteriorate. Typically, the protein leak is the first symptom. Loss of kidney function happens much later. And then we can stage it based on how significant the amyloid deposits are. And these are how some of the patients might present to us. They can be bruising around the eyes, so-called periorbital purpura, enlargement of the tongue. There can be changes in the nails. The tongue typically gets enlarged, and you see these indentation marks around the teeth on the tongue as the tongue gets enlarged. There can be carpal tunnel syndrome or deposits of amyloid in the carpal tunnel, leading to wasting or difficulty in using the muscle joints. Occasionally, you can have localized lumps of amyloid in different organs and tissues, and then you can have amyloid deposits in the kidney, which can lead to swelling and renal impairment. ATTR amyloidosis, on the other hand, is a much simpler disease. It typically affects the heart, leading to cardiac symptoms. It can lead to carpal tunnel syndrome, typically a few years before the diagnosis of the cardiac amyloidosis. It can affect the lower back, leading to spinal stenosis because of amyloid deposits in this ligament in the spine. And sometimes it can affect the lungs. But we are not going to talk a huge amount about ATTR, but we'll touch upon it very briefly. How do you diagnose amyloidosis? And we'll come back to that in a minute. We have to use a combination of tests, assessment of organ function, and then organ-specific tests for amyloid diagnosis. So typically in our head, we have 4 different steps. We need a tissue diagnosis. So we need to take a tissue sample on a biopsy, typically, to show amyloid under a microscope. We can use it to confirm that whatever symptoms are going on are because of the amyloid deposits. We can then take these biopsies and do some special tests on them to type and find out what kind of protein is causing amyloid. As I said before, we've got maybe 30 different types of amyloid proteins, of which 3 or 4 are common. And we need to know what type of amyloid is actually causing the damage. So typing is really critical because the treatment is entirely dependent on what type of amyloidosis one has. If it's AL amyloidosis, the treatment goes down the route of chemotherapy. If it's ATTR amyloidosis, the treatment goes down trying to stabilize the TTR protein or reduce the production of the TTR protein by other different mechanisms. Once we have got amyloid deposits already identified, we then have to define what is the underlying clonal disorder. What is causing the amyloid protein, which is these abnormal plasma cells that I showed you. We need to find out how many are there, what kind are there. Once we have identified that, we need to look at biomarkers, which tell us how damaged the different organs are, which allows us to figure out what the prognosis of the patient is, and then we need to image amyloidosis. So when we need a tissue biopsy, we can either biopsy the organ which is affected by amyloidosis, which has got the highest chance of being positive. But sometimes the organ biopsy may not be that straightforward, particularly if it's the heart or the kidneys or the liver, where there may be some risks involved. And we typically do what's called as an abdominal fat biopsy. You can see here with a syringe and needle, someone's taking a little sample of fat. And here is a little syringe with a little bit of fat in it. And when we stain it with this stain called Congo red dye, and we look at it under the microscope, particularly with what's called as polarized light, when the light is only in one particular direction, you get this what's defined as an apple green birefringence, which is typical for amyloid diagnosis. Once we have diagnosed amyloidosis, we go on to look for the clone. We look for abnormal cells in the bone marrow, and what it tells us is that if there are more abnormal cells, then the disease might be more aggressive. If there are less number of abnormal cells, the disease might be less aggressive. And then we go on to do imaging to find out where the amyloid is. There are lots of different ways of imaging amyloid deposits, and I'll show you some of them in a minute or two. We can do what's called as a PET or a PET scan with this tracer called as flu beta pair. Originally, it was developed for Alzheimer's type of amyloid. And you can see that the heart lights up when this tracer is imaged. We can do MRI scans of the heart with amyloid imaged by a specific tracer called gadolinium, or we can do a scan called as a DPD scan, which is also very important in amyloid diagnostic algorithm. MRI scan is probably the most sensitive and specific method for amyloid diagnosis. So if someone suspects amyloidosis, you want to know, oh, is this patient's heart damaged because of amyloidosis? The most sensitive, specific test for it is an MRI scan. We give a tracer called gadolinium. It's given into the heart. And normally when the gadolinium contrast is given, this is the heart muscle, which should look black. This is the blood inside the chambers of the heart, which should look kind of the grayish color. What you find in amyloidosis is that this has been reversed. The heart muscle, you can see very well defined, thick, and there is what's called as enhancement of the heart muscle, which is very characteristic of amyloid. The blood becomes black. So there's a reversal of how the heart should look. This is a patient who has got lots of amyloid in the heart, so the entire heart wall is white. This is a patient who has got early amyloid in the heart, and you can only see a rim of whiteness just around the cavity called a subendocardial gadolinium. The same happens in AL amyloidosis or ATTR amyloidosis. You can see that the heart is thickened and there is abnormal kinetics of this tracer called as gadolinium. This scan is available in most major hospitals, and this is being used to diagnose amyloidosis. And certainly the very early graph I showed you, where more and more patients were being diagnosed with cardiac amyloidosis, coincided with the advance of imaging and the availability of MRI scanning for amyloidosis. DPD scan or a PYP scan is a particular kind of bone scan. It's been used for many, many years, and this is how a bone scan should look like. It should look like a skeleton. You should just see the bones, maybe a little bit of soft tissue, and this is what a bone scan look like. But in TTR amyloidosis affecting the heart, all of this tracer is sucked up by the heart and the muscles, and the bones have essentially disappeared. And when you have this kind of an uptake in the heart with no abnormal proteins in the blood, we're able to diagnose TTR amyloidosis. In AL amyloidosis or light chain amyloidosis, the bone scan may either be completely normal or it may show a hint of uptake in the heart, and that we use that to differentiate between the two different kinds of amyloidosis. So we have already suspected amyloid. We have done the biopsy. We have made the diagnosis. We now need to go on and figure out what to do with it. So amyloidosis is treatable. That's the most important message. Majority of the patients these days will respond to treatment. AL amyloidosis is treated with chemotherapy treatment, really aimed at killing off the bad plasma cells in the bone marrow. Unfortunately, we can't cure amyloid, and we don't have any licensed drugs which will help to dissolve the amyloid, but we'll come back to this in a minute. The goal is to get remission, which means to put the disease back into its box, to say that way, and then allow the amyloid protein to be dissolved by the body. And the final goal of treatment is to prolong life, improve quality of life, and prevent further tissue damage. But we have to balance all of that with the risks and side effects of chemotherapy, at the same time controlling the disease symptoms or reducing the disease symptoms. Lots of treatments have happened over the years, and this is a chart which shows how treatment has changed. But essentially, the point of this graph is when we started treating amyloidosis, and this is even before I got into amyloidosis, maybe only 30% of patients would respond to treatment. 70% of patients did not respond to treatment. We are now here, 2024, 2025. And what we can see is that close to 90 to 100% of patients respond to the chemotherapy treatments that we have access to. And some of these treatments are licensed for amyloidosis. Some of these treatments are licensed for multiple myeloma, but used for treatment for amyloidosis with very, very good effect. When patients with amyloidosis are treated, the light chain protein, which is at a very high level, with treatment drops down to a low level, sometimes back to normal, these days in maybe 60 or 70%. And then we call it as patients are in remission. They're not cured, but they are in remission. And this period of remission will last for a while, which might be months, maybe many months, with certain types of treatment, even many years. But at some point, these free light chains or the plasma cells start to grow again. And this is called as relapse, when the light chains are growing again, and the patients will need treatment for a further time point. And our goal really in amyloidosis is to get this remission as fast as we can, ideally within 1 or 2 months of starting treatment. And then the second goal is to maintain this period of remission, or this plateau phase, as we might call it, for as long as possible, because this is the time where your body will try to dissolve or remove the amyloid deposits. This is where the organ function will recover. Once the light chain's protein starts to come back or relapses start to occur, then the disease symptoms start to recur. And the goal, again, is not to wait till this happens before we start treatment, but to start treatment here as soon as we notice that there's a relapse happening so that we can stop the damage from recurring. And whatever benefit, improvement in organ function has happened over this period of time, we don't lose that improvement in organ function before we start treatment. So the goal of treatment in amyloidosis is to start treatment early, get a rapid response to treatment, maintain that response to treatment as long as possible, knowing we can't cure it. When the light chain protein starts to go up, treat again very quickly. There are a number of different things we do when the patients with amyloidosis are treated. We are treating immune cells. We're trying to kill immune cells. So infections is a problem. So patients get antibiotics. They get antivirals, antifungals if needed. Sometimes there's a risk of blood clots forming. So we give blood thinners. As I said to you, the heart rhythm might become a bit irregular. So we may have to give drugs which may stabilize heart rhythm. Patients may be anemic. We can give drugs to help with blood counts. There's often retention of fluids. So we give diuretic pills or water tablets, monitor weight very closely. We have to adjust the fluid balance for kidney function, give plenty of diuretics. There's often weight loss or loss of appetite. So we have to give dietary supplements. And treatment of amyloidosis, therefore, becomes quite multidisciplinary. The hematologist will administer the chemotherapy. We require cardiologists to deal with the cardiac problems. We require kidney doctors to deal with the renal problems. We require nutritionists, dietitians, physiotherapists to help with all of the other complications which happen. And therefore, a multidisciplinary team is absolutely critical to managing a patient with systemic amyloidosis. The side effects of treatments, unfortunately, sometimes overlap all the problems that are already there. Some of the drugs that we give may lead to further fluid retention, heart and kidney. They can cause irregular heart rhythm. They may cause renal impairment. Some of the chemotherapy drugs can cause nerve damage and lead to neuropathy. There is already a problem with taste because of tongue involvement in amyloid patients. The chemotherapy can make this worse. And therefore, managing all of these side effects and keeping a close track record of your side effects is absolutely critical. And you need to let the healthcare team know which side effects you're suffering from and be in close contact with the healthcare team. Certainly within our own practice, we are in contact with our patients maybe twice weekly. We see them in the clinic once a week. We get one of our nurse specialists to contact them once or twice a week to go through other side effects so we can monitor, but also intervene very early before the side effects become significant. Until fairly recently, as I showed you, we have treatments which can eliminate the plasma cell clone. It can suppress the production of this abnormal protein, and that's really where our focus was. And that whole chart I showed you from 1990 to now, we have had lots and lots and lots of treatments, and we have become more and more efficient in being able to target this side of the pathway, which is the production side. What we have not been able to do so effectively is to target the other side, which is the aggregating protein. We haven't been able to stop these aggregates from forming. And then we haven't been able to remove the amyloid protein deposits. But we now have therapies, which are antibodies, monoclonal antibodies, which can target the amyloid fibrils. There is one called KL101, which has completed phase 3 clinical trials. There's another antibody called bertamimab, which is also in phase 3 clinical trials, which can target the misfolding protein or the aggregating protein we call as soluble toxic light chain aggregates. But they can also bind to the amyloid. And when they bind to the amyloid, they identify to the immune system as, hey, this is an abnormal protein, let's get rid of this. And then the antibodies can get rid of the amyloid protein much faster, allowing us to recover the organ function. So we need to switch our focus from simply attacking the production to actually tackling the problem itself. And we've got some very exciting phase 3 clinical trials which are completed or about to complete. And we look forward to seeing the results of these clinical trials, which will tell us that we can target not only the production, but also the actual problem and treat amyloidosis with a bidirectional approach, clearing the deposits and stopping the production, at which we are very, very efficient. ATTR amyloidosis, and I know we're talking about AL amyloidosis, but is also the other common disease. And there are a number of different drugs which are now available for ATTR amyloidosis. We can stabilize the TTR protein with a drug called tafamidis. We can reduce the production of the protein with these very fancy agents, which can target the genes in the liver and switch off the gene production of the TTR protein, a drug called vutrisiran, which has recently been licensed for TTR amyloid cardiomyopathy in both wild type as well as hereditary amyloidosis. And then TTR amyloidosis is also a focus of a gene editing or a CRISPR-Cas9 gene editing sequence, where we can literally chop out the TTR gene and stop it from making the protein forever. And this is a very exciting therapy for amyloidosis. We have got monoclonal antibodies also available for ATTR amyloidosis. So treatments can be given to control AL amyloidosis. They will stop the production of the deposits, prevent new deposits from occurring. During treatment, supportive care is really, really critical to control the side effects, but also control the disease. Initial treatments depend on what kind of amyloid deposits you have, how severe is the organ involvement, whether you are going to move on to intensive chemotherapy or where we have to be very gentle. The treatment is based often on what's approved for myeloma, because only one particular drug is approved for AL amyloidosis. And lots of drugs are being studied as parts of clinical trial. And you should ask your team whether there is a clinical trial with either a drug which is targeting the plasma cell pathway or a drug which is targeting the amyloid deposits, which is aware or there. One of the critical things which is important in amyloidosis, and this is really where we need to educate our physician colleagues, is in patients who have a monoclonal gammopathy or this abnormal protein that is very common, 5% of the population, when to suspect amyloid. When patients with NMGUS develop unexplained symptoms, which are not MGUS symptoms, like profound fatigue, unexplained breathing difficulty, start developing breathing problems, bruising, edema, new onset tingling numbness, persistent diarrhea, nausea, weight loss, amyloid needs to be thought about. Older adults where there's no particular reason for why the heart is not functioning very well, or where the ECG and the echocardiogram look abnormal, we get this combination of autonomic nerves and peripheral nerve involvement, which means there's low blood pressure with peripheral neuropathy. Proteinuria, unexpectedly severely raised cholesterol, is often seen in patients who present with proteinuric or nephrotic syndrome and amyloidosis. So one of the questions we get asked is, could this all be amyloidosis? The answer is yes. It's not a medical curiosity, as many doctors used to think. And it's far more common than we think, particularly ATTR amyloidosis, but even AL amyloidosis. Patients may have potentially a wide range of presenting symptoms which lead to amyloid, and therefore early suspicion is important. And the right patients need to be investigated for where amyloid is there and where amyloid is not diagnosed. But it's still an uncommon disease. So don't think that every symptom, every little edema on the feet is amyloid related. And therefore, you need to have the right investigations and the right tests to be done. So amyloidosis is something that we need to educate both patients and physicians into saying that this is a diagnosis that you have to think of. You have to think of it early. And clinical suspicion on the part of the physician is really critical, as it's an uncommon but not an ultra-rare diagnosis. I think that's my last slide. So thank you all very much for giving me this opportunity to talk to you today about amyloidosis. I thank all my colleagues at the National Amyloidosis Center, colleagues at University College Hospital, where we run all our clinical trials and treatment, and a lot of studies we have done with our global colleagues and collaborators in this rare disease area. And thank you all very much for listening to this talk. And thank you, Mandy, for inviting me here today.
Thank you. Thank you, Dr. Wechalekar. That was excellent. Really great information. And I encourage people to put any questions they might have into the Q&A or the chat. I have a few questions, if you don't mind. My first question is around what's the age of onset? At what age are people typically diagnosed or symptoms first start to emerge? And then also, what's the genetic component? So is this a genetic disease or is it both, like ATTR is both? Is that the same for AL?
So AL is not a genetic disease. So that's the easier question to answer. It's not familial like ATTR is. AL amyloidosis typically happens in the mid-60s. The average age of onset is in the mid-60s, but it can happen from any age above 30. It gets commoner as people get older because this condition called MGUS is commoner in older adults. And therefore, amyloidosis is commoner in older adults. And we are seeing more and more patients aged over 70 and over 80 with amyloidosis. So the average age in our patient population is late 60s.
And do you see it all over the world? And is it seen in certain populations more often than other populations?
We do see it in all populations in the world. It is being diagnosed more in other areas where amyloidosis was difficult to detect. It is slightly more common in the Afro-Caribbean population who have a higher risk of MGUS, the African American population or the Afro-Caribbean population in the UK. They have a slightly higher prevalence of MGUS, and therefore they have a slightly higher prevalence of amyloidosis. But overall, the prevalence is probably very similar across the globe. It's diagnosed a lot more in the Western countries because they have got more access to healthcare. Biopsies are done more often. But as healthcare becomes more prevalent, we are seeing the same number of patients being diagnosed in other countries as well.
And I think watching this, for me, the question of access is a huge one, because people have to wait so long to get a diagnosis. And if they aren't living in a big city that has a good center of like a center of excellence or a good healthcare system where you've got these multiple groups working together, right? Because you're not a cardiologist, you work with cancer patients. So when you've got different, I mean, how difficult is it for people to get this diagnosis? And what's your hope for the future in terms of seeing this change?
So I think I'll answer the second one first, because I think that's kind of aspiring to what I really want. I said in one of my slides that one of the challenges in amyloidosis is we don't have a single test which makes a diagnosis. And that's what makes it so difficult, because it's always a combination of suspicion, imaging, biopsy, which then leads to diagnostic tests. We are hoping that in the next 2 to 3 years, we'll have a simple blood test for patients with monoclonal gammopathies, which will tell us whether the protein in their blood is unstable, whether it's sticky, whether it's got a propensity to form amyloid. There's an assay which is in clinical trials called Amyloid, which for the first time over the last few years can detect if those light chains are unstable in the blood. And we hope that this assay might be a test which in the future might allow us to suspect amyloid very early in patients with monoclonal gammopathies. What happens at the moment is that patients often come with a number of non-specific symptoms to their primary care physician. Then they get bounced off to either a cardiologist or a nephrologist or whoever else, depending on which organ is affected. And at that point, the suspicion is raised. And from my perspective, what I try to say to physicians as well as to patients is that amyloidosis is a multi-system disease. If you've got a patient with more than one organ system which is affected at the same time, heart failure, kidney failure, heart failure, nerve damage, and there isn't an obvious reason for why that is happening, then they should start thinking about amyloidosis as a potential diagnosis. There are some conditions, for example, diabetes, where you can get these things, but otherwise, patients who have been completely fit and well suddenly come with a combination of 2 or 3 different systems which are going wrong. You start thinking about amyloidosis. That's our message. Something is wrong where you've got more than one organ system in an otherwise healthy adult, then it has to be amyloidosis. There are a number of other systemic diseases where these things happen, like sarcoidosis, where you need to start thinking of a multi-system systemic disease rather than go down the route of one specialty. We would also recommend doing biopsies early, because those biopsies can be done in any hospital, particularly where there is protein leak from the kidneys. Access to imaging like MRI scans, echocardiograms are available everywhere. And people need to suspect amyloid when they suddenly see a patient with a low blood pressure and a thick-walled heart.
Yeah, and so that's something, because for us, we can't impact what the physicians do, but we as patients and organizations can push our patients to ask those questions and to keep saying, in this case, can you do a biopsy? Is that a reasonable ask to your doctor if you're not getting the answers?
So the first thing is to do some form of imaging, because that is non-invasive. So it's very easy to get an echo, a cardiac MRI, very high specificity for diagnosing amyloid. If a patient has protein leak from the kidneys and you haven't got an answer, then you need to go to a nephrologist and request whether there would be a role for a kidney biopsy in that setting. And those are the 2 common organs that would cover 80% of patients with amyloidosis. There is no non-invasive way of diagnosing kidney amyloid. So that needs a biopsy. But for cardiac amyloid, MRI scan is a very non-invasive, widely available method for diagnosing amyloidosis. So an echocardiogram is available with every single cardiologist, and they can very strongly suspect amyloidosis based on echo features. So even a simple echocardiogram with the right suspicion can lead to the amyloid diagnosis. So if somebody has got progressive symptoms of cardiac failure, which are not being very clearly identified, then they need to start asking questions about, I don't have hypertension, I don't have heart disease. Why am I in heart failure? What is the thing? Is amyloidosis one of those rarer conditions that's being missed?
And Susan asks, what type of physician is recommended to begin to diagnose when a cardiologist isn't familiar with this disease? So I guess if that cardiologist isn't finding the answer for you, what's the next step after that?
I think if the cardiologist isn't finding the answer, if it's only cardiac symptoms, then I guess you need to try and get a referral to a more specialized center, because you might need more specialized imaging if the amyloid isn't very clear on regular routine imaging. But if it's more than one system involved, then sometimes a hematologist might suspect amyloidosis, particularly if you have an abnormal blood problem along with your heart problem, because they would often do a bone marrow. We can find amyloidosis on bone marrow biopsies. But the thing you need is good imaging. And good imaging will always diagnose cardiac amyloid, even very, very early. Echoes and MRIs. And therefore, if you're not sure what's going on, then do get yourself referred on to a tertiary referral center where there may be access to slightly more complex imaging than that might be available in community hospitals.
Thank you. Mark asks about cholesterol or calcium. Can it affect amyloidosis in any way? Is there any relationship between the two?
Calcium doesn't affect amyloidosis in any way. Cholesterol directly doesn't affect amyloidosis, but patients who have got leaky kidneys, where the protein leaks out of the kidneys, can have very high cholesterols. Because of the protein leak, the body's reaction is to produce more cholesterol, and they require treatment for it in due course.
You had mentioned also about hypertension symptoms can actually improve. Can you kind of explain or elaborate on that? I was curious.
So what we often find is that people who get systemic amyloidosis, cardiac amyloidosis, have been hypertensive sometimes for many years, and they then notice that they're feeling very tired, their blood pressure suddenly starts to become normal or drop below normal. And that's because their heart isn't able to pump blood as strongly as it was before, so they really can't maintain such a high blood pressure. And for us, that's a big red flag. If somebody who was hypertensive all their lives, requiring treatment for hypertension, suddenly, in absence of any particular reason, becomes normotensive. If there was a very good reason, if they genuinely went on to a serious weight reduction program or whatever else, and their blood pressure normalizes, a different story. Or if they had a kidney disease and that was treated, then it's different. But otherwise, if suddenly somebody who was hypertensive becomes normotensive, which is normal blood pressure, or hypotensive, which is low blood pressure, we would be strongly concerned that there was something wrong with the heart. May not be amyloidosis, maybe some other kind of heart problem, but or other kind of problem which affects the blood vessels which maintain your blood pressure, nerves which maintain your blood pressure, so neuropathy of some kind. And that definitely requires investigation. It's a big, big red flag. One thing which I always tell my physician colleagues is that we never see a patient with bad cardiac amyloidosis with a high blood pressure in AL amyloidosis. So it doesn't happen. You don't get systemic AL amyloidosis and hypertension in the same patient. Almost never.
Thank you. So I don't see any other questions in the chat or the Q&A, but this has really been enlightening. And I think it's just the first that we're starting to hear. And hopefully over the next 5 years, we start to hear a lot more as it becomes easier to diagnose and treat.
Great.
So
thank you very much for inviting me to talk to you and your group of patients. Hope they found it useful.
Yes, thank you so much. Oh, I do have one last question. Are cardiologists able to detect, I guess, he's asking, is this something that a younger cardiologist might be able to identify a little bit easier than perhaps someone who might be closer to retirement?
I won't go into that, but
Are the medical schools, is there more education being done in the medical schools about AL amyloid?
I think let's put it this way. Amyloid has actually become a new disease, which cardiologists love. It's a new toy that they've got. For many, many years, we could not engage cardiologists to think about amyloid. They would not diagnose it. And now actually they have got, because TTR amyloidosis is a disease of cardiologists, not of hematologists, and they can treat, and there are drugs which are licensed for ATTR amyloidosis. They're certainly thinking about amyloidosis a lot more than they used to think even 2 years ago. Every single cardiology meeting in the world has got like an entire symposium on amyloidosis, when 2 years ago, it would be tough for us to get a 5-minute talk on amyloidosis there. So these days, cardiologists do suspect amyloidosis, and they do suspect it early, both younger and older cardiologists, because it's their new favorite toy. It's a new disease that they've suddenly discovered. The important thing is that they forget that there are different kinds of amyloidosis. They only think of TTR amyloidosis.
Mhm.
And our goal is to tell them that, yes, amyloidosis affects the heart, but it's not one kind. It's more than one kind. So if any cardiologist diagnoses amyloidosis, they have to follow the full diagnostic pathway. Otherwise, they don't know what type of amyloid is affecting the heart. So we are running into this issue of, yes, cardiologists are aware of amyloid. They have got a drug that they can prescribe because it's a pill. It's easy to give. And TTR amyloid is a cardiac disease, so they think every amyloid is TTR amyloid. And AL amyloidosis, which is a completely different kind, then often becomes forgotten for a while, and the patients can be mistreated until other symptoms become apparent. So we are in this era where there is overdiagnosis in some instances, and there is misdiagnosis in some instances. And then, of course, there's still this huge issue of underdiagnosis. So we are into all these three places where some people are diagnosing too many patients, some people are diagnosing patients but not doing all the workup that's required, and therefore they're not diagnosing them correctly. And there are other areas where people are still not thinking about amyloid. And depending on which city or a hospital you live in, you can be in any of these three groups.
Really interesting. Thank you. It's a great perspective. Okay. I think that's everything. Those are all the questions. Thank you again. It's very enlightening. And thank you to everyone on today's call. We really appreciate you being here.
Thank you, and thank you for inviting me.
Thanks. Have a good day.
Good evening.